Dear colleagues, good evening and welcome to this European School of Urology webinar on personalized medical treatment for male LUTS. This is the first webinar from a series of 3. I am Stavros Gravas, and together with Professor Jean-Nicolas Cornu and Mr. Sachin Malde, tonight we'll critically review the contribution of the EAU guidelines in the field, discuss what our patients want from medical treatment, and set the requirements for the optimization of personalized medicine. Please do not forget, you can send your questions through the system and we will try to reply to all of them after our presentations. So I think it's time now to share my screen and upload my presentation. So the topic of my presentation is the contribution of EAU guidelines recommendation to individualized treatment. And this is my potential conflict of interest related to this presentation. So personalized medicine is an approach to medical care that tailors therapy to the individual characteristic of each patient. This approach has been mainly applied in the field of oncology. As a result, targeted therapies have been introduced thanks to the molecular characterization of the cancer that allows new knowledge into the prediction of the disease progression and in response to the treatment of each patient. The concept of individualized care is not a new one. Actually, it's a very old one. It comes from the era of Hippocrates. As urologists, we are familiar with several nomograms and prediction models that have been developed recently in urologic oncology with elevated accuracy, good calibration, and promising decision analysis. Some of them have integrated genomics that further improved prediction. And the field of prostate cancer is a perfect example of these nomograms and prediction models. However, we know from our daily practice that we treat different subpopulation of patients with LUTS because of benign prostatic enlargement. Living in the era of aging male, we have more and more older patients who suffer from severe comorbidities, who are usually under anticoagulants or antithrombotics. And this can result in longer waiting lists and in prolonged hospitalization. On the other hand, we treat patients who are younger or fit, and they are very much interested in ejaculation preservation. And we all know very well that our patients have different baseline characteristics. They have small prostates, big prostate, prostates with a middle lobe, without a middle lobe, and they have different values and preferences from their treatment. And also there is some discussion and research about genomic differences between the patients with LUTS. To be honest with you, I think that we do offer individualized care to our patients spontaneously in some cases. And I will give you the example of alpha blockers. When we discuss about our patients, about the treatment of male LUTS, we have the option of alpha blockers. And we know that on conceptual basis, all alpha blockers have a similar efficacy, but they have a different profile of adverse events. So when we select together with our patient the alpha blocker, then we can select based on the preference of our patient. If we have one who is interested in ejaculation preservation, we will select an alpha blocker who has lower chances for ejaculation dysfunction. Or if we have a patient with severe cardiovascular problems, then we will go for a highly selective alpha blocker. It's obvious that not all our patients are the same. And we know very well that treatment decisions not aligned with the clinical characteristic may result in suboptimal treatment. Recent evidence shows that patients with LUTS because of benign prostatic enlargement have different rates of disease progression. So ideally, we as clinicians, we would like to have the ability to predict treatment response and select the right treatment for the individual patients. And for this reason, we should take into account the baseline characteristic, comorbidities of our patients, adverse events, values, and preferences. And this is where the EAU guidelines come in. We know very well that EAU guidelines are dynamic, they depend on the available evidence, and there is a continuous evolution. It's a huge number of publications every year, and this is the reason why the EAU guidelines panel on male LUTS performs an annual scope search in order to update the guidelines. And the concept of individualized treatment has been introduced in the EAU guidelines on male LUTS, where, first of all, in the assessment. Then, in the formulation of our recommendation, we also did a systematic review on values and preferences of our patients, and we developed the algorithm. So let's go one by one. Clinical assessment. The clinical assessment of patients with LUTS has two main goals. The first one is to make the differential diagnosis in order to find the reason for the occurrence of male LUTS, because we do know that male LUTS have a multifactorial etiology. And the second goal is to define the clinical profile, including the risk of disease progression, of the patient who is sitting in front of us in our office in order to provide the appropriate care. And we need to take the personal values and preferences and the individual circumstances of the patient into account. This is what the EAU guidelines recommend, and this is completely in line with the principles of individualized care. When we develop a recommendation, we always evaluate the evidence behind that. So we look at the quality of evidence, the balance between the benefit and the harm, the values and preferences of our patients, and the cost. And when we take into account all this, we can reach to a recommendation which is strong or weak, against or in favor of a specific test or a specific treatment. And we try to do our recommendation as actionable as we can. And what does that mean? It means that a recommendation should say to us what to do to which patient under which specific circumstance. And for this reason, we need to use a clear language. The recommendation should be implementable, and we should be able to measure the impact of our recommendation on daily practice. This is a systematic review on patients' values, preferences, and expectations that our panel performed. I'm not going to present the details of this systematic review because I do know that Mr. Malde will present in his presentation after me. So the main findings from this systematic review were that men consistently preferred less invasive management options with low risk of adverse events, and the sexual adverse events such as erectile dysfunction, loss of libido, and ejaculatory dysfunction were more important in preference decisions than non-sexual adverse events. And almost 93% of our patients would prefer a treatment with no sexual side effects. Men valued improvement in urge incontinence over other symptom improvement. In addition to that, daytime frequency and nocturia were very disturbing symptoms because they disrupt daily activities and sleep, and also result in decreased self-confidence of our patients. Our panel has also developed several treatment algorithms in order to assist clinicians to select the right treatment for the right patient. And this is the medical treatment selection algorithm. You can see there are three important decision points. The first one is the presence of nocturnal polyuria. The second one is which type of symptoms is predominant. And the third one is the size of the prostate. If you look at the invasive treatment selection algorithm, then you can see there are also three decision points. The first one, if the patient can receive anesthesia or not. The second one, if the patient can stop antiplatelet or anticoagulants or not. And the third one is, again, the size of the prostate. And there is a continuous evaluation of our guidelines. And I will give you two examples. The first example is from medical treatment, and the second one is from the invasive treatment. So you can see that, for example, for the combination of alpha blocker with 5-alpha reductase inhibitor in 2004, actually we didn't provide any kind of recommendation. We provide a kind of summary of the available evidence. But in 2022, we have a more individual approach. The recommendation is clear. Offer combination treatment with alpha blocker and 5-alpha reductase inhibitor to men with moderate to severe LUTS and an increased risk of disease progression. If you look something similar from the invasive therapies, I can give you the example of prostatic urethral lift. In 2016, the recommendation was that prostatic urethral lift leads to objective and subjective short and mid-term improvement, and randomized controlled trials with longer follow-up are required. In 2022, we have a very clear definition of the patient, of this individual patient who will benefit from the treatment with prostatic urethral lift. Offer prostatic urethral lift to men with LUTS who are interested in preserving ejaculatory function with a prostate smaller than 70 mL and without middle lobe. So you can see the evolution and the contribution of our recommendation towards the individualized care. Of course, there are some limitations. Guidelines are dependent on the available evidence, and the highest level of evidence comes from randomized controlled trials, but even pivotal randomized controlled trials provide mean results for an average patient profile from a defined population. And if you look at the post-hoc analysis coming from randomized controlled trials, they help to understand treatment response in subgroup of patients, assessing the impact of one at a time baseline characteristic on disease outcomes, instead of evaluating the result of multiple parameters interaction. So there is a gap in our knowledge and there is a gap in the literature. So in conclusion, there is an obvious need for individualized treatment of men with LUTS. So individualized treatment is not only for oncology, but it is also applicable to benign conditions. EAU guidelines did the first step. They have recognized the need for this and contributed to the adoption of individualized treatment. There is a gap between this well-recognized need for personalized approach and what we do in our daily practice due to the lack of data and information. Clinicians and guideline developers ask for studies on the individual patient level and the impact of multiple baseline parameters interaction on disease outcomes. So thank you very much for your attention. Again, I would like to invite you to send any questions to through the system, and we will try to reply to all these questions after the presentation. So I think it's time to move to the second presentation. The second presentation is about the values and preferences of our patients, what our patients want from medical treatment, and it will be given by Mr. Sachin Malden from UK. Sachin, please.
Great. Thank you very much, Professor Gravas, and to the EAU. It's a pleasure to be part of this webinar and speak to you today about patient values and preferences. What do we know? I'm Sachin Malden. I'm a urologist from London. So I have no conflict of interest related to this talk. So we start here with the treatment options that are available for lower urinary tract symptoms secondary to benign prostatic enlargement. And actually, if you look through the guidelines, there are upwards of 15 different options now for treating or managing symptoms due to benign prostatic enlargement, ranging from the most conservative options, such as watchful waiting or behavioral and dietary measures, through to the pharmacological therapies, combination therapies, and then on to more interventional treatments, like transurethral incision or resection of the prostate, enucleation procedures, vaporization procedures, embolization, water jet ablation, prostatic urethral lift, other mechanical devices, and water vapor energy. And so, as such, there's now a lot of choice for treating men with lower urinary tract symptoms. And with choice comes increasing kind of need to really work out what patients' values and preferences are, because now a patient's faced with many different options, each with different benefits, risks, burdens, different profiles for each specific treatment. And a patient now has a lot to think about, not just how effective is the treatment, but also what are the complications? Will it affect my sexual function? What's the recovery like? What are the risks of long-term complications? What is the cost? And what is the length of hospitalization? A huge number of factors that are not even on this slide. And I think with so much choice, it really highlights the need to explore patient values and preferences in detail so that you can offer individualized approaches. So we know that the optimal management for LUTS does require consideration of values and preferences taken into the context of the individual patient, their own personal background. And it's not just related to treatment options. Actually, values and preferences, experiences are related to the whole pathway of men with urinary symptoms, from health-seeking behavior and barriers that will facilitate us to health-seeking, through to diagnostics, pharmacological treatments, and surgical treatments. If we look first at health-care-seeking behavior, why patients seek care, there have been studies and surveys looking at this in the past, specifically related to benign prostatic enlargement. And we all know, we see these patients, there are various reasons that men present, often from fear that it may be cancer, wanting to exclude prostate cancer as a cause, but also the level of bother of symptoms, the embarrassment it causes, the impact on their work life, their social life, and their personal relationships. And interestingly, what physicians may think differs to patients' views and patients' beliefs. And this survey again showed when surveying urologists and patients that there was a discrepancy between the two, that in fact patients valued treatments that reduced their risk of complications from benign prostatic enlargement, such as needing surgery, over rapid symptom relief, whereas most physicians would typically prescribe a medication that results in rapid symptom relief, but less so a medication that would potentially reduce the long-term risk of needing surgery. So it just highlights that discrepancy between physician views and patient views. And we know that the level of bother of symptoms is one of the main factors that drives men to seek care. And this study shows, really looking at a population-based level and an individual level, what the most bothersome symptoms are that lead men to seek care. And this is important because it comes in a bit later to when we're talking about values and preferences around treatment, in that the most common reasons that the most bothersome symptoms for men tend to be the urgency, post-nutrition dribble and nocturia symptoms, rather than avoiding symptoms. And symptom persistence is another big factor, as well as bother, that leads men to seek care, especially persistence around nocturia. So what we did as part of the guideline group is to review all the data, and the data kind of spanned over decades, looking at values and preferences around both the diagnostics and treatment of male lower urinary tract symptoms. And we looked at qualitative and quantitative studies, specifically in adult men, excluding any studies on prostate cancer, incontinence, neurological disease. And actually, after reviewing all the studies available, we found 29 studies that were eligible based on the inclusion criteria, looking specifically at patient values and preferences. The majority of these were quantitative studies, for a very small number of qualitative studies, and one mixed method study involving over 9,000 patients. The majority assessing lower urinary tract symptoms in men due to benign prostatic obstruction, 2 studies related to overactive bladder. And we tried to assess what we know already about values and preferences related both to diagnostics, pharmacological treatment, and surgical treatment. So if we look first about what data there is on values and preferences around diagnostics, we found studies looking at two main diagnostic areas. One is around bladder diaries, the other around urodynamics. In general, we found that there was variable preference between paper and electronic diaries that actually varied depending on the population that you assess, that electronic diaries were easier to read and discrete, more likely to be completed. But again, that did vary depending on the patient subgroup. In terms of urodynamics, we found that although men, especially younger men, found it painful and embarrassing, overall they found it acceptable as a test because of its perceived diagnostic insight in helping to improve their symptoms. If we look at pharmacological treatments and the studies around that, we had a slightly higher level of evidence when looking at the pharmacological values and preferences. And interestingly, men value treatments that improve urgency incontinence more than the other symptoms. They value a treatment that avoids sexual side effects, as well as one that reduces the risk of retention and need for surgery. Men also value rapid symptom improvement, but actually it seems that the improvement in urgency incontinence is valued at highest. In terms of surgical treatment, we found, consistent with previous studies, that men prefer less risky options. And interestingly, men will tolerate symptoms, put up with a certain level of bother to try to avoid surgery until the point where the symptoms become bothersome, more severe. And they also prefer treatment, unsurprisingly, when there's a higher rate of success with a lower risk of complication. Interestingly, around sexual function, again, this was variable. And most important for men who have a higher baseline level of sexual function, not so much for those with lower baseline levels of sexual function. So it gave us some data that's not too surprising, some data that's very interesting. And one thing it really highlighted was the fact that this area is quite difficult in terms of methodology of study, and both quantitative and qualitative methodologies are important. We found that the current evidence is limited in the use of validated research tools and quantitative methodology, and there are much fewer qualitative studies currently in the literature. Overall, the evidence, as mentioned, was low to moderate. A more recent study, though, using very kind of strict methodology with a conjoint analysis methodology, a discrete choice, found consistent findings without a systematic review, that men actually most value treatments that minimize complications, and that ejaculatory dysfunction actually was the least important, and patients are more interested in recovery and risk of complications. But of course, that's not a blanket across the board finding, and it's not a one size fits all. And in fact, in certain subgroups, ejaculatory function was more important. So I think the main take-home messages about what we know already about values and preferences in this area of male lower tract symptoms is that number one is very important. With the level of choice available for treatment, we know that assessing and exploring patient values and preferences for treatment is essential for optimal care. We know that overall, men prefer treatments that have lower risk, that have fewer sexual side effects, and that primarily improve urgency incontinence and nocturia. And we know that there is room for further research in this area to fill some of the knowledge and evidence gaps that we have at the moment. So thank you very much for your time. Thank you for listening. And I will pass on now to Professor Jean-Nicolas Cornu. And I'll just stop sharing my slides.
Yeah, thank you very much, Sachin. So we now share my screen, and should be okay. So I'm pleased to be with you today to discuss the further options we have to evolve in this personalized approach for male LUTS medical management. These are my conflicts of interest. I mean, I mainly act as a member and now chairman of the EAU guidelines panel, and I work with a lot of companies involved in that topic, of course, as all researchers. So we will discuss today the current armamentarium and treatment pathway briefly. This is in connection with what Professor Gravas has summarized. Then we will see in what way we can improve things. First, on patient workup and characterization of the symptoms, including the clinical picture, patient expectations, and doctor expectations. And then we will see how we can evolve in the medical treatment prescription field, focusing on symptoms, risk-benefit balance, and associated care. So first, I would like to put a little bit of context here. We have escaped now from more than a decade from the simplistic view that all LUTS are due to the prostate. We know that it is not the case, and it is not the case for voiding symptoms, for storage symptoms, and also for nocturia. Let's take a look at it. When we talk about voiding symptoms, we know that the causes are multiple. It can be a matter of benign prostatic obstruction, of course, but it can be also because the bladder is not working correctly with an underactive detrusor. It can be also a dyssynergia of the bladder neck. Immediately, you would say that in a patient facing voiding LUTS, to personalize treatment, you would like to know the real cause underlying this. So it's absolutely important to have this in mind to try to make the best diagnosis, to individualize a treatment. If we talk about storage symptoms, which are included in the LUTS field and which often coexist with the voiding symptoms, we know that the OAB origins are multiple. Actually, the prostate is hardly involved in that case. It can be because of the bladder is not working properly with detrusor overactivity. It can be because of autonomic dysfunction. It can be because of associated disease. And we all know that other conditions like affective disorders, metabolic syndrome, microbiota, and a number of things can interact with this. And if we can know what is the target, we could finally personalize treatment. But at least if we are not here yet, we at least need to have this in mind. If we talk about nocturia, which is probably the most challenging thing, we have several causes here for nocturia. And you see that among all these causes, having a BPO responsible of this is only one of the possible etiologies. For nocturia, you have 4 diagnosis boxes, which are namely the sleep disorders, which have nothing to do with the prostate. If you have primary sleep disorders, you wouldn't heal the patient with prescribing any drug for the prostate, for example. You have the field of nocturnal polyuria, which is one very important point because we have here the sleep obstructive apnea that can be a pitfall in the evaluation. We have the 24-hour polyuria, of course. So if you don't do the bladder diary, you cannot characterize your patient. And you have the reduced bladder capacity, which can be linked to BPO itself. So if you have all this in mind, you might see the patient differently and come back on this very basic algorithm you all know. You may come back on the first blue box on the right, which includes history, symptom questionnaire, urinalysis, physical examination, PSAs. It looks like very basic thing, first grade options, but it is damn important, because if you do not see at this stage what are the pitfalls, you may not have the good results with your treatment. So it's very important to have the correct evaluation of symptoms bothered by the questionnaire. Sexual function has to be assessed. The frequency volume chart is part of the evaluation, especially if you have storage symptoms or nocturia. It is absolutely important to characterize this. Of course, uroflowmetry, PVR, and by ultrasound can approach the evaluation of the bladder emptying. And you have the associated conditions that are, of course, neurological disease, prostate cancer or suspected prostate cancer, infection, and the big box of physical examination. If you go further through the evaluation about the treatment algorithm, you would see that the requested items to personalize treatment, according to all these blue boxes and arrows, are evaluating the bother, frequency volume chart, the questionnaire, and the ultrasound with prostate volume. This is what is guiding you today. So this is the background. How can we progress on this? How can we get deeper? First, we have in the literature a lot of data showing that we have other items in the medical history and the physical examination and in the clinical context, which are linked with LUTS. So beyond all these basic things, we may approach the issue of frailty of the patient, look for cognitive impairment, looking for diabetes, looking for constipation, and characterize the metabolic syndrome and obesity. We treat all these kind of patients every day, but obviously we do not care about all this in our treatment decisions for the moment. Cardiovascular disease have also been shown to be linked to LUTS. So that may be in the future things to invest and look in the clinical studies to see if it is predictive or not of the outcome of treatment, which has not been done today. Some of the things are postulated, but they may have huge clinical importance. Depression, stress, and anxiety are linked to storage symptoms. Sleep disturbances, night shift working, and circadian disorders have been linked to nocturia, of course. The other big field is microbiota. You know that it is probably a part of the future to characterize the background and the symptoms and the pathophysiology of LUTS. For the moment, we have no clinical tool coming there, but this may be part of the future. And then other items like autoimmune diseases have been postulated and toxic consumption, including marijuana. So if we just take the example of diabetes, I mean, you take diabetes at a part of the medical history of all your patients, I'm sure, but I think you like me, I mean, if you look at the guidelines, you do not take that into account to prescribe the drugs. If we look at this, we perfectly know that diabetes is leading to a mixed bladder dysfunction that is associating potentially underactive bladder with impaired contractility, loss of sensation, and increased post-void residual, and as well as overactive bladder with potentially urgency, pollakiuria, incontinence, nocturia. There are some very strong hypotheses explaining why diabetes are leading to these symptoms. So we may ask the question, if the patient has a diabetes that is absolutely in complete imbalance and impairment, should we act on this before doing something related to the prostate? Indeed, the diabetes mellitus have some effect on the neurons with the neuronal dysfunction. There is some smooth muscle dysfunction and also urothelial dysfunction. You see all of these figures and letters. I'm sure you know them, especially the P2X3 and these new receptors that are individualized in the urothelium. I think that drugs that are targeting all this pathway may be very interesting in the future. But today, there is no correlation with especially indications for LUTS medical management, I have to admit it. If you look at the microbiota, I say that there were some clues that it have been linked to bladder dysfunction. It is true. You can look at this table and see where I packed all the recent studies that have been linking the microbiota to the LUTS items. You see that it is linked to the flora, of course. It is linked mainly to storage symptoms, probably by the way of inflammation. Today, it doesn't imply any specific prescription, but we all know that infections and dysbiosis and microbiote is an issue in patients with male LUTS. So that may be a field again that would come very active in the next years. So if we look at the current display we have in the guidelines, explaining to our readers that we have several causes of LUTS, some other causes like microbiota, obesity, hormonal, urothelium aging, and brain integration, also metabolic syndrome. It is a whole field that remains to be investigated. So now if we look to the other characteristics of the patient except the associated disease, we can look to characterize the patient to the bladder and the prostate itself. What do we have? For the bladder function and bladder characteristics, we have a number of items that have been described in the literature. Bladder wall thickness, endoscopic view, is there any columns, any cells, any trabeculations? We have the urodynamic studies and also data on the vascularization of the bladder wall with the NIRS, near infrared spectroscopy. Today, we haven't validated any of these items as a predictive factor. It's the same thing for the prostate shape. I know that the intravesical protrusion index of the prostate has been postulated, but there is indeed still nothing clear regarding this. And neither for the dynamics of the prostatic lobe while voiding. But this said, we must admit that we have more and more knowledge about the modifications of the bladder and its components when it is subject to chronic obstruction. We know that from this work by Fusco that when the obstruction is lasting for years, you have several stages with the bladder that first can be hypertrophic, that can compensate for the obstruction and then can decompensate. Obviously, all the patients we see are in their decompensation phase because they have symptoms, but it is hardly defined today what is the neuron degeneration level, what is the smooth muscle cell degeneration level, what is the urothelial dysfunction degree in these patients. We do not know, and we treat them like a big group, but they are probably completely heterogeneous. So again, we don't have any clue for immediate use in clinics, but it is something we will have to work on. So if we get another step forward and we look at the literature and the studies, the medical studies we have, when we look at the efficacy of this medical treatment of LUTS, it is assessed currently, of course, by the impact on the IPSS. I mean, in the field of medical treatment, the IPSS is the leader. This is what I call the IPSS dictature. It is comparable to what we have for surgical treatment that has been looked only as a Qmax issue for years. With your surgical treatment, you must get the best Qmax, and with your drug, you can have the best IPSS decrease. But there are another way to analyze this, and Dr. Malde has shown that a number of other values and preferences are important. But at the moment, you can see in the literature that there are a number of efficacy parameters that have been assessed, mainly questionnaires, but no expectation, value, or preferences has been yet the primary outcome of any study about a drug treatment in male LUTS. But this is precisely what we need, because when we look at the guidelines, as Professor Graf has said, we must look at these patient expectations, and we must do more and more for this, not only look at the literature results, degree of evidence. It's more qualitative. So how can we move forward? Probably by involving patients in the guidelines group and asking them what they want and giving some further studies, including patient-reported outcome measures, PROMs, that are to be issued, I think, in the next year. It is mostly qualitative, but when you look at it, you see that it is completely different than simply looking at the IPSS. If you look at all the dimensions of what impact a patient, of course you have efficacy, but you have also tolerance and other domains. It is related to symptoms, of course, but also quality of life, satisfaction, and also the psychosocial aspects, the goal settings, expectations that have to be met. So it is a global measure, and if we look at this, it's quite difficult to implement. Ideally, a patient-reported outcome instrument has to include a number of dimensions, including medico-economic aspects, and it is quite difficult to set. Some rules have been issued by the ICI consultation in continence a few years ago. To date, we have only some emerging work. I gave you one example as a conclusion for the future. That is this work about OAB. So the authors started from the theorizing, the conceptual framework. They outlined the instrument. They authentified the evaluation of the measurements needed. They collected, interpreted data, and adapted their pro-instruments with a lot of qualitative works. It ends like this, that has been proposed by Con Kelleher and his group for the field of storage symptoms. They tried to develop a specific tool for OAB that was issued from elicitation interviews, cognitive interviews, and several back and forth meetings with the researchers and the patients. They ended with a validated tool, but if you can take a look closely at this paper, it will give you a clue of how difficult it is to theorize the values and preferences of the patients. So I think, like, as a take-home message for the future, personalized medicine is originally from Hippocrates, but it is also the future because this is what patient wants. First, at this stage today, I would recommend that before any prescription, identify any confounders and have a perfect picture of the patient. Take a bit of time to know who he is, to know how all the associated conditions can impact the result of your treatment. For each drug prescription, we must assess the benefit to harm ratio, patient values and preferences, of course, as Dr. Maldo said. But the most important is that facing these multiple options, the patient has the choice and we guide them the most precisely as we can, but we will meet this goal only with adequate studies, with using patient-reported outcome measures that are essential. So I thank you very much for your attention, and I think we are now ready for your Q&A session based on your numerous remarks we have on the Q&A boxes.
Thank you, Jean-Nicolas. If you can stop sharing your screen, then we can move. Yeah, perfect. Yes. And also Sachin can join us. Yes, it's correct that we have received several questions from our participants, and I would like to thank you to thank you all for their interaction and feedback. So I have one question for you, Sachin, and the first question is, what is the panel's opinion of patients understanding the usefulness of LUTS investigation tools? Is there any evidence on how comfortable they feel about that? You mentioned something about pressure flow studies, but what about the other investigation tools?
Yeah, it's a good question. I mean, when we reviewed the data that was out there, in terms of investigations, there wasn't a huge amount actually on the different investigative options on non-invasive urodynamics, ultrasound. It was mainly actually on urodynamics data from upstream, the qualitative aspect of upstream, which suggested that men, if they perceive the test to be important in their treatment pathway, in the treatment decision, then they're willing to put up with a certain degree of pain and embarrassment. That was kind of finding from that study, but we don't have any other data on other kind of investigations and how men find those.
Any comments, Jean-Nicolas?
No, I think that when we look at for these pressure flow studies, and what is very important is to connect and have the perfect correspondence between the patient's symptoms and the pathophysiology that is going under this. So we are all eager to have simple tools to get deeper in understanding clinically and easily what is happening with this, particularly in the case of voiding symptoms. But today we don't have any reliable tool that is replacing all this. So we have some reference tests, but we have also, I think, the experience about all these cases. What I didn't say it because it's quite qualitative, but my intuition is that it seems like a simple area. When you have these patients, you can just give them the standard drugs you learned during the medical school and it will be okay. But you have indeed an incredibly complex world with taking all these men with LUTS. They are all different. They all want different things. They do not live in the same timing and they have so different expectations.
Correct. And correct me if I'm wrong. We know from our clinical experience that it depends also on the severity of symptoms and if our patients are happy with the current treatment. Because we know, for example, that they hesitate to fill the bladder diaries, for example, sometimes. But if they are not happy with the treatment or they have severe symptoms, you can see that patients are comply and they can fill the bladder diary. So it depends on the person, but also on the severity of symptoms and if they are happy with the treatment or not. There is another question for you, I think, Sachin, but we can also discuss if there is any data suggesting variation in expectation of sexual function preservation between Asian and European men.
Yeah, interesting question. I personally don't know of any data that exists comparing those. We know from a lot of the studies that there are differences in different subpopulations, so based on age, but a lot of the values and preferences studies that are out there are purely based on European or American men. Very few studies in other populations. So actually, I suspect there may be a difference, but there's no evidence that I know of that has shown that yet.
Okay. And in addition to that, there is a question that just popped out. If there are any racial disparities in diagnosis and management of male LUTS?
Racial disparities in diagnosis and management. I'm sure there are. Again, when we look at the evidence in this, very well, no evidence really comparing the different racial groups. I think we're a bit limited to know for sure, but it's a big area actually that we need to look into because what we've reviewed applies to one population, but doesn't really account for lots of other racial areas.
I think that there are some studies coming from the United States that show that there is there are some differences, but I don't know if we can if they are applicable to Europe. I mean, but as you said, we have some only low evidence studies exploring this condition. I think there is I'm looking, there are a lot of questions coming, and I think there is a question for you, Jean-Nicolas, and because one of our colleagues also point out the very important issue of follow-up of our patients. So the question is, how much do you believe that post-medical therapy assessment for LUTS with EuroFlow and not only with IPSS affects the perception of patients about medical therapy?
Well, this is an absolutely key question, because there is a difference between the symptoms improvement and the EuroFlow improvement. For example, it's good to see that a patient is happy with the treatment, but if you follow up and you do the uroflowmetry and you find, for example, an increasing PVR, or you think something that is worse, you would say to the patient, well, you are not going so well. You say, but I'm happy with this. What's wrong, doctor? So what is important to assess is the context and what we can anticipate. What is the good moment to switch and to be more aggressive? When is the pathology, when is the disease, when is the disease is progressive? You have a number of clues. I would say never focus on one parameter. The patient feeling is one thing, but you can be used to your symptoms. You can take bad habits, and so you have to look carefully during follow-up at the IPSS, but also the Qmax, PVR. I do this, of course. I think if we do a ultrasound to correct also, you can follow up the PSA, you can follow up the prostate volume. And finally, what is important is that you look at the expectancy of this patient. Will he end his life with a low pressure bladder and something acceptable? Or do we have maybe a decompensation phase that is lasting too long, and we will, even when we operate, have a bad result? One open door, I think, Professor Gravas, in this field, is maybe switching medical therapy when it doesn't work to maybe minimally invasive options, because for years we had only the pills and the surgery, ablative surgery. And we didn't know what to do with these patients who are not doing perfect with the drugs, but you do not feel happy to operate because you think it's too much. We have here expanding options here. This landscape is still a bit blurry in terms of indications, but I think gradually we have to inform the patient what is on the journey and what is possible in the coming years for him, so that he has, a bit of a taste of the future.
And again, there is another question. How often do you suggest to repeat questionnaires or any kind of investigation tools in LUTS patients after treatment? So are we talking about individualized follow-up?
This is an absolutely excellent issue. I didn't work on it for this talk, but I think it is absolutely important. If you look at some patients, that we have, for example, young patients with a kind of progressive condition with already a very high PSA and severe symptoms. You can say, well, take your phytotherapy or your alpha blockers and it will be okay. We have to look at them. They have a potential of evolutive disease, and we do not take that as a full chapter. I think it in the guidelines we have a kind of uniform recommendations, but I think this is something we can progress on definitely.
Okay, so Sassin, there is a question coming from Morocco. Some patients are not eligible for surgical treatment, but they are for all medical treatment fields. How do you manage this frequent situation?
Yeah, it's good. It's a good question, and so many patients can't have traditional surgical options because of various comorbidities, and you're kind of left with a situation where you're struggling with medical therapy, but you don't have much else anywhere else to go. But I think that's where a lot of these newer treatment options and minimally invasive options have opened up kind of a door now for some of these patients that can be done under local anesthesia or very minimal sedation. And actually, I think with so many options available, it's much more likely that you can find something that would work for an individual patient based on their specific risk profile. So I think hopefully becoming less and less of a big problem.
Correct. And Nicola, you mentioned something about microbiota in your presentation. So can we use urinary microbiome analysis to select patients for medical treatment, or this is too much complicated?
It is for the moment. It's not possible because we do not know exactly what is the influence of the differential microbiota we have in these patients. We know that we have some differences in terms of type of species and amount of different species in patients with different symptoms. So it is just something that we have something clinically significant. So maybe this microbiota is linked to the symptoms. At the moment, we cannot use that to propose, bladder instillations, antibiotics for a long time, or select any validated medical treatment for LUTS. But maybe it is something in the future we will correct first. When we have a patient with a lot of infections, but really serious, like 5 episodes in 1 year with fever or something, you are not so confident to just roll on it and give a standard treatment. You try to solve it. So I think we will identify in the next future patients with a dramatically modified microbiota that need to go further in terms of explorations. For the moment, I would not also recommend this because the methods are not perfectly okay in terms of consensus. We have several ways to look at the bacteria. You can look at the ribosomal DNA, RNA of the bacteria. You can look at their enhanced urine culture, enhanced quality urine culture, EAU. You will see that coming in the next years very much, but it's not standardized. So for the moment, I would not recommend to put any hope immediately on it, but that would be something important. One thing I didn't talk about in the personalized follow-up, it is blowing in my mind right now. I will think about it all night. It is probably the biomarkers. We had a lot of data, BDNF, about NGF, about a lot of things that are produced by the urothelium. We didn't succeed to select patients based on this 10 years ago when this research have popped up. But probably it is reflecting the way the bladder compensates and the bladder works and the bladder ages with this obstruction in place. And this is probably an area that we have to look at to identify patients where you think you are doing well, but for the body itself, you are not doing that well, and obstruction is still persistent, and you are taking a risk for the evolution.
I think it's a very interesting field for the future. Sachin, you mentioned you presented about the values and preferences of the patients, but what do you think about the influence that physicians themselves have on the treatment choice that patients make?
Yeah, I think that there's a big influence that we as physicians, urologists have on our patients, and actually our own personal views about treatment based on our experience of what we think works well and what we think doesn't work well, definitely influences what patients think. And there was a previous study, the PROBE study from Emberton, which looked a bit at physician attitudes and patient attitudes, and there was that discrepancy. But I think the big area where we need to focus, because I think if we have our own pre-existing beliefs or our own pre-existing preferences, that will inevitably affect what the patient thinks. It may not be completely accurate based on the data.
I would like to thank you very much for your participation. I think that we ran out of time. So I would like also to thank the participants for their interactive participation, and also the European School of Urology for giving us the opportunity. And lastly, our sponsor, GSK. I would also like to invite all the participants to the second webinar that will go live on 7th of December. So thank you very much for your participation. Thank you very much for the attendance. I wish you a very good evening.